Hey everybody, can everybody hear me? Fantastic. Okay, so we got a few more folks that are joining in. Um, so I'm going to give it a few minutes. If we don't get started right at 12, honestly, it's not that big of a deal because I doubt that we're going to go the full 2 hours. So we probably will end a little early today. I'm also attempting I said a little early, not a lot early, okay? So, if you're expecting this to last to like 12:15, I'm sorry to disappoint you. Um, So I'm also trying to get my share button to work on Microsoft Teams. It's currently being a little unresponsive, I guess would be the term. So let's go ahead and I'm going to continue to try to get this thing to share. If not, then literally what we'll do is I want you guys to open up the PowerPoint slide and I'll just have it up on my screen. You guys will have it up on your screen and I'll tell you when to like switch slides and things. So we'll make it work regardless. Obviously, with the technology, it's great when it works, which is rare. So how's everyone doing today? Everyone enjoying the snow day? Everyone like stay safe from like snowmageddon that we had here locally? Everyone stock up on bread and milk and stuff? French toast supply is fantastic. Fantastic. Yeah, I gotta say, I was a little disappointed in the lack of snow. Yeah, I heard a couple more inches or a couple inches is supposed to come later, but I gotta be perfectly honest with you that I will believe it when I see it, and even if it does happen, then I think we're gonna be okay. So in order to kind of use time efficiently, it doesn't look like the share button's gonna work on my Mac at home. I apologize. So what we'll do is I'll pull up the PowerPoint slide and we'll just kind of do the voiceover version of this. I am recording it, so if you guys want to go ahead and like I said, if you have insomnia and my voice puts you to sleep, turn me on at 10:30, 11 o'clock at night, and you'll go right to sleep, right? All right, so I am going to pull up the slide now. We're going to start on slide 1 of the DPT 6420 week 2. This should go very, very well with what you guys are covering in your MSK course right now. So the first thing I wanted to bring up on slide 1 here is how prevalent non-mechanical conditions and visceral disease is when it comes to the lumbar spine. So the big thing to note on this slide is that mechanical low back pain, leg pain, those are going to be 97% of your cases, right? So when we talk about all these other alternative ankylosing spondylitis or, whether it be a aortic dissection or cauda equina, understand that every therapist out there has that one story or two stories out there, but the vast majority of time our patients are going to come in and they're going to be mechanical back pain. Okay, or they're going to be mechanical leg pain. So the nice thing is that you can always kind of default to the mechanical side. The bad thing is you're going to go years in seeing low back patient after low back patient after low back patient, which a lot of times what that does is that makes you a little biased, not necessarily as vigilant as you should be when you're looking at these other conditions. But what we will look at is some very easy, cheap, honestly, very cheap ways that you can differentiate some low back pain, mechanical versus non mechanical, in your everyday outpatient clinics and even in an acute care setting if you work in that setting as well. So we're on to slide 2. Low back pain of systemic origin red flags. These are the big ones, right? So my patient comes in, they are going to need to show me multiple red flags. Okay, and that's going to be a really important point because if we look at any one of these red flags, any one is not necessarily going to be enough evidence that my patient has systemic low back pain. So if my patient's a child, right, if they're under 20 and they have low back pain, okay, that's going to be something I need to look at. Does it mean that if my patient's 14 years old and they have low back pain, that they automatically have something like multiple myeloma? No, absolutely, it does not. But if my patient's coming in and they're 14 years old and they have low back pain, I need to take a pretty close look at them. The big one, history of cancer. If my patient has a history of cancer, then I need to be very vigilant that the cancer has not come back or it's gone into another part of the body, such as the low back or lumbar spine, and it's kind of doing its thing and rearing its ugly head again. So what we're going to see is a recurring theme throughout this entire lumbar section, and you guys have already seen based on last semester and even a little bit of this semester, my number one sign, my number one red flag for cancer is a previous history of cancer. Also, think of some of these other bullet points that are on here. Okay, so if my patient's not improving with physical therapy, number one, you really don't have a lot of evidence to continue to treat them. Number two, that's a red flag in itself, right? So that's kind of that category 3 red flag, if I remember from last semester. So if my patient's not improving, I need to probably refer them out to another provider. If my patient has something like pelvic or abdominal symptoms or saddle anesthesia or progressive neurologic signs, right? So my leg pain is getting worse and worse and worse, then maybe they don't belong in your clinic. Maybe they belong somewhere else. And as we can see, and as we're going to see, a lot of these red flags are going to have very specific diagnoses attached to them. So this is a good little case example to start with. Okay, so we're on slide 3 now. So what we have here is we got a female cadet. They're about 19 years old. They came right in through direct access. 1 week history, insidious onset low back pain, radiating to the right flank. No trauma. What makes it better? Not really sure. Just kind of comes and goes. What makes it worse? It just kind of comes and goes. What makes it better? Really nothing. It just kind of comes and goes. No fever, chills, nausea, nothing like that. No radicular symptoms. So what I want you to start thinking about, are there other questions that we need to ask? And really what should be kind of pinging in your head right now is, well, I need to ask some more questions about urination maybe. Maybe I need to ask some questions about weight gain or weight loss. Maybe I need to ask some more questions about certain positions that may feel better or worse. As we're going to see, positioning is going to be a key component to whether or not someone has something like ankylosing spondylitis versus another sort of pathology. So we do an objective exam on her. Lumbar looks great, range of motion's fine, hip range of motion's fine. Nothing we do, no poking, prodding makes any change whatsoever. We do repeated motion testing. It makes no change whatsoever. We do selective functional motion assessment. That's SFMA. That makes no change whatsoever. She's kind of tender when we poke at her paraspinals in her right flank, but it's just kind of all over the place. It's not really anything to localize or specific. And, we're kind of sitting back, scratching our head a little bit, and our patient goes, oh, by the way, not sure if you can help me with this or not, but it burns when I pee. Okay, well, that just changed the game significantly, right? Because this patient may not have a radicular symptom, right? Or low back pain or a disc herniation. Typically, that symptom that she described is typically most commonly associated with something like a UTI. So if my patient has a UTI, that can refer pain to the right flank, can refer pain to the low back, simply because of the lumbar plexus connections there, right? Okay, so think back, way back to anatomy, and think back to, your iliolumbar and iliohypogastric, right? Remember those guys, ilioinguinal, right? All those nerves that come through, they all originate in your lumbar spine. So think about how that referral pattern would happen. And then it kind of makes sense how this patient would have that sort of symptom that presents as low back pain. All right, so we're on to slide 4. So this is kind of just a review slide. I'm not going to spend a ton of time with this. Cervical spine, very common area of MSK pain, but there's a ton of overlap, right? There's a ton of stuff that it can be or can't be. Thoracic spine, obviously, if my patient's having thoracic spine pain, there's a ton of organs, right? So as we know, my patient could have some sort of cardiomyopathy, right? They could have some sort of heart attack, ischemia, something happened that refers pain to the interscapular region. Also could have some sort of tumor in proximity to the spinal cord and thoracic spine as well. As we learned last semester, also things like compression fractures. The scapula tends to be a very common area for GI referral. And my scapula, just because of their positioning, and just because if you remember way back in the very beginning of Anatomy 1, we kind of talked about how the scapula start out kind of in the center and then they just kind of migrate to the back, but they take all this other stuff with them. You guys remember like hypaxial muscles and epaxial muscles, right? Those hypaxial muscles being the extremity muscles and the epaxial muscles being the deep back muscles. Lumbopelvic referred pain, we got a lot of abdominal organs there. As we're going to see as well, I can have a lot of other symptoms coming from especially ovaries, uterus, fallopian tubes, things of that nature. So here's a couple conditions that can cause pain in the lumbar spine. Now remember, go back to that very first slide. So we're on slide 5 now. These are only going to be about 2% of my low back pain patients, right? So 97% of the time, it's mechanical. These are going to account for all these little 2%, these one time in your career or 2 times in your career patients. But I can't have a patient come in with something like an acute appendicitis. And what they're typically going to see is going to mirror basically what an appendicitis would be. Think about where that appendix is. It's in the right lower quadrant. It's going to refer pain in the right lower abdominal, and sometimes it kind of wraps around and refers into the lumbar region. Typically, they're going to have right iliac, right lumbar direct tenderness. It's when you push on it, it's really going to hurt. Think about way back when we talked about McBurney's point, kind of halfway in between the ASIS and umbilicus. That's typically where that appendix is going to sit. Associated signs and symptoms. Anorexia, I can't eat anything because it hurts too bad. They're throwing up all the time. They're nauseous all the time, right? That doesn't go along with your garden variety low back pain. None of those do. If my patient potentially has an abdominal aortic aneurysm or common or external or internal iliac aneurysm, because they can happen anywhere, what I'm going to see is that my patient's going to have just kind of this vague abdominal pain, vague low back pain. They can have radiating pain to the low back, flank, or the groin. And what we're going to see is that not only are they going to have a palpable pulsation in the abdomen above the umbilicus, but they're also going to complain typically of a throbbing low back pain, right? So we kind of think about what throbs in the body. My arteries throb in my body. My arteries pulse in my body, right? So typically, if I have pain that's vascular in nature, I'm going to have this throbbing. Sometimes it's a crushing, sometimes it's a burning sensation. So if my patient's complaining of that, I typically need to palpate where the aorta is and in relation to the spine. And remember that if I can feel a pulse 4 centimeters away from where the aorta should be, that's going to be at least enough evidence that they need to get looked at. So, and these things can happen all the time. I can remember, actually, this was not in your cohort, but the cohort prior to you, one of the cadavers had a AAA. And it was about the size of a golf ball. And, the students asked me, would this person feel that or not? It's sometimes yes and sometimes no. Because really the risk with a AAA is not the fact that it's there, it's the fact that it can grow to the size and stretch the arterial wall so badly that it rips and dissects. And if your abdominal aorta dissects, you don't have a lot of time to live, right? You're going to go down pretty quickly. So this is why if these patients show these signs and symptoms, we can be very proactive and not allow that aorta to dissect. So that's why this is important. All right, so we're on to slide 6. So ectopic pregnancies, this one can happen. Be careful with this one, okay? There are sometimes that folks can have an ectopic pregnancy. Sometimes they don't even know they are pregnant, because sometimes these can happen very, very early in the fetal cycle. Okay, so watch out with this one with obviously your female patients. One big question that you probably need to ask, and I would highly suggest it on your intake paperwork, is there a possibility that you're pregnant, right? Or when was your last menstrual cycle? Because as we're going to see, especially sometimes with our younger population, if you think about it, some of the younger females, maybe they aren't on a regular cycle just yet. And maybe they're active, and there's a possibility that they're pregnant and they don't know it. So they go in either through direct access to your clinic or they go in primary care. Hey, I have just kind of this abdomen pain, pelvic pain, low back pain, whatever it is. And my teammate went to physical therapy. Can you send me to the physical therapist? Sure thing. Go right ahead. They come to you and they don't have a disc herniation, right? Or they don't have facet joint arthropathy. They're having an ectopic pregnancy. So you need to ask these questions. And do you have any sort of change in your menstrual cycle? Are you having painful menstruation? How do you describe your back pain? If it's kind of this sharp ice pick stabbing low back pain, then we need to investigate further. Are they having referred pain into their neck or their shoulder? That's another big question to ask, right? Think about your lumbar discs in the intervertebral disc space and the intervertebral spinal roots. In the lumbar spine, there's nothing that goes up to the shoulder or the neck. So there's something else happening there. Endometriosis, again, this is another condition that if I'm having back pain or my patient's having back pain that worsens with the menstrual cycle, we need to investigate that a little further. Not saying that every single patient that has low back pain that worsens with the menstrual cycle has endometriosis, but it's not a bad idea to get them in to a gynecologist and have them take a look, right? Because what we don't want to do is we don't want to miss these things. Also, if they're having painful rectum or they have rectal pain or painful defecation, that's a red flag for a lot of things that are not within the scope of practice of a physical therapist. So if my patient's complaining of those sorts of issues, remember the change in bowel and bladder, that's a red flag. So I maybe have enough evidence here to send them out to another provider. So that way we can at least get them checked out. Not saying they're not going to come back to your clinic, because the other provider checks them out and says, hey, they look fine to me. Go right ahead and do therapy. That's great. Then we've done our job. I'd rather send that patient out and get a no than not send them out and miss it. All right, so we're on to slide 7 now. So a couple other issues that can happen in the lumbar spine. I can have a conus medullaris problem, and typically conus medullaris because it has a very specific blood supply to it, and we didn't really cover this real well in anatomy. I can have neurologic symptoms if my conus medullaris itself is not getting the appropriate blood that it needs. Typically what I'm going to see here, if we kind of think about where conus medullaris is, I'm typically going to have lumbar or lower thoracic pain. Think about where conus medullaris terminates. It's typically right around L1. However, the literature says anywhere from T12 down to L3. So conus medullaris typically around L1, but it varies on the person. Multiple myeloma. Typically what we're going to see with multiple myeloma is that they're going to have very big low back pain, or sometimes not, but typically they're going to have some pretty considerable low back pain. They're typically going to have a dermatomal sensation loss, right? So when I do my dermatome testing, they come up positive on their dermatome testing. And then some weakness and numbness in the lower extremities. Now, with multiple myeloma, obviously we see the suffix oma, which indicates an oncological pattern. We're going to marry those signs and symptoms with our red flag symptoms, right? So are you having pain at night? Are you having pain, that doesn't change with a change in position? Do you have changes in bowel and bladder? Do you have, a weight loss or weight gain? Things of that nature, right? So we're not just going to go simply say, oh, my patient has low back pain and they have a dermatomal sensation loss. Hey, you have multiple myeloma. No, because there's a lot of things that can cause dermatomal sensation loss. But what we do need to do is take a closer look at it. All right, so we're on to slide 8. So Cauda-Equina syndrome, again, this is another one. You're going to get it once in your career, maybe. Estimated prevalence 0.04%. So, if you really think about it, you're not going to see it that often. I've had one in my career. I know that we have someone in class already that's had one in their clinical affiliations. Like I said, somebody in the third year cohorts already had one in their clinical affiliations. That is unbelievable. Good luck or bad luck, depending on how you want to look at it. But it does happen, and we really do need to screen for it. Most commonly, it's going to happen L4, L5. Number 2 most common location is going to be L5S1. The one that I had was an L5S1. In our disc herniation population, typically 1 to 2% are going to have it, and they are going to go basically straight to the line for surgery because that is an emerging condition. So on to slide 9. This table comes straight out of the APTA's clinical practice guideline, and it comes from Kroll's work in 2009 as well. That's where they got it. So as you can see here, urinary retention, that likelihood ratio is pretty good. It doesn't get much better than that. So if my patient comes in, they have some low back pain, and I ask them, okay, are you doing okay with urination? No, I'm not. That's pretty darn sensitive, and that's pretty darn specific too. And we really need to, at that point, say, okay, I think you need to go get this looked at. Now, what they're typically going to do is they're typically going to do an MRI. Sometimes the patient will get the radiograph MRI special, if you will. They'll get both. But typically they're going to go straight in for an MRI on this one. But as you can see, a lot of the other signs and symptoms are pretty sensitive, but they're not necessarily that specific, right? So even things like bilateral sciatica, that's pretty sensitive, but it's not specific to Cauda-Equina because a lot of things can cause bilateral sciatica. So just be careful with this. That's, like I said, pretty easy question to ask. Are you having any urinary problems? Yes. Okay, we need to really get you in specifically for Cauda-Equina. All right, so I'm on to slide 10. Now, this is the other thing to watch out for with the patient, okay? And this is why I would highly recommend that everybody in the office that's going to come in contact with that patient can understand the signs and symptoms. And this is what happened to me. So about 30% of patients that have Cauda-Equina syndrome The first manifestation is a lumbar disc herniation. What typically happens is that they go from low back pain to cauda equina in about 24 hours. And this is exactly what happened to me. I evaluated the patient on a Monday. Yeah, I got 3 out of 10 low back pain. And this person was a CrossFitter and about 33, 34 years old, in pretty good shape. Yeah, I just got this central low back pain and it just doesn't feel real good. So, what did I do? I went in, assessed. Okay, let's go ahead and we did our PIVMs and PAVMs, and I did like some PA glides and things like that with it. Felt pretty good, right? Walked out, got off the table. Hey, I'm feeling pretty good. Okay, let's go ahead and let's see you back on Wednesday. Person comes back in on Wednesday. Hey, how you doing? Well, back pain's coming back. It's like a 4 out of 10 now. It's a little worse. And I don't know if this matters or not, but I'm having a heck of a time holding my bladder. Oh, okay. So I literally took my hands off the person and said, that's not good at all. I'm going to go ahead and who's your neurologist? Oh, use the folks across the street. Fantastic. I'm going to go call them, tell them what we got. They said, get her right over here right now. So said, okay, they want to go ahead and check you out. Hopefully everything's okay. And, let me know what happens. So person called me back up 2 hours later. I'm really glad you did that because they're sending me in for surgery tomorrow. Now, the reason that I say everybody in the office needs to know this is because in a lot of outpatient therapy clinics, typically your therapist is going to do the evaluation, and then maybe a PTA, maybe a tech, maybe another individual is going to provide or at least be part of that treatment, right? Even that person, if you think about it, I do the evaluation on Monday. I need the tech to go get them set up on the bike on Wednesday. And that patient's going to tell that tech a lot of things. We need to cue the tech that, hey, when the patient says these sorts of things, you need to come get me. I don't care what's happening. So remember, no matter who is seeing that patient, you're going to be ultimately responsible for them, right? So everybody in the office needs to communicate and communicate well. All right, so we're on to slide 11. So big systematic review happened here about 8-9 years ago in the British Medical Journal that I thought was really interesting. And they did a huge review of malignancy and fracture in patients with low back pain. Big thing to take away from this slide, and I know the red box kind of got moved a little bit. History of cancer is your number one predictor if someone potentially has cancer. So and it doesn't matter what type of cancer it is. If they have a history of cancer, the antenna need to go up, and we need to understand that they potentially have, or they maybe have cancer happening again. Not saying it's definitely happening, but we at least need to look for it. As you can see, all the other big red flags, age, unexplained weight loss, all the rest of the stuff, it really didn't have a great likelihood ratio, right? Because lots of things can cause weight loss, right? Lots of things can say, well, I didn't improve, right? I mean, let's face it, even with age, if we think everyone over 50 has cancer, that's going to be an issue, right? And it's not that specific. Okay, so on to slide 12. The big thing with this slide is the little box down there in the corner. I'm going to read it because it's important. So our review shows that the advice provided in some guidelines to refer all patients with a single positive red flag for imaging is unwise. Given that 80% of patients in primary care might have at least one positive red flag, such a course would mean that most patients with low back pain would receive diagnostic imaging. And that is exactly right. So one red flag tells me nothing. I need to have other red flags as well. Like I said, the big one is history of cancer. I can rule out cancer. I can say this person doesn't have cancer if they meet these 4 criteria. They're under 50 years old, no prior history of cancer, no unexplained weight loss, and they get better with conservative management, right? That makes a lot of sense. If my patient's going to therapy and their back pain's getting better with therapy, they probably don't have cancer, right? I can say that. However, if my patient's over 50 and red flags are present, I can still rule out cancer with anterior, posterior, and lateral plain film radiographs and an erythrocyte sedimentation rate blood test. So if their blood test comes back fine and the films come back fine, they don't have cancer, right? Because we would have seen it. MRI sensitivity with cancer, and this is where I get a little sketchy with MRI, only about 83 to 93% sensitive. And that's kind of a problem, especially when it comes to something as serious as cancer, because if 83% of my patients are showing positive with cancer, that means 17% aren't, right? That means it's not popping up in the MRI and they still have cancer. That's kind of a problem. So be careful. Just because that patient had an MRI and just because they come in and said, well, I had an MRI and it didn't show anything or it didn't show cancer, that does not necessarily mean they don't have cancer. They need to have these other tests done to rule it out. So we're moving on to slide 13. Infection's a big one. Now, we're going to see infection, and we're going to see infection not necessarily terribly often, but enough that we need to rule it out and we need to screen for it. The big one we're going to see infection for is our post-surgical folks or post-diagnostic procedure folks, such as spinal taps, right? Such as bone biopsies, right? If I have something getting put in my body and is introducing a hole or a wound, that wound, no matter how big or how small it is prone to infection. So I need to really watch out for that. So my folks that have had, a lumbar fusion done, or they had a discectomy done, or whatever it is, what I always tell my patients is that our number one goal with you is to not get an infection. Number 2 is let's get the healing process started, right? Let's not kind of put the cart before the horse, as the old saying goes. Because number 1, I need to make sure my patients don't get an infection. Now, typically what I'm going to see with infection, constant back pain, gets worse at night, right? That should be a red flag. The pain may refer to the abdomen, doesn't always have to. If they have big spasms, if they are very rigid, if they list or they really kind of limp to one side or favor one side, that might be a sign of infection, but not necessarily that specific. If they have a spasm that happens with a straight leg raise test, and I think that's the test you guys either have already covered or you're going to cover in MSK, what we're going to see is that positive straight leg raise test is going to tell us a lot. So there might be an infection happening if we see those things. We're going to move to slide 14. Now, here's the big thing with infection, okay? And this is probably more the important slide when it comes to infection. Approximately 50% of the trabecular bone must be lost before a lytic lesion is visible on a radiograph. What does that mean? That means that 50% of my bone's got to be gone before it's going to show up on a radiograph. So again, if that patient goes in and they have low back pain and the radiograph comes back fine, it does not necessarily mean they don't have an infection, right? Because 50% of bone is a lot, right? That's a lot of bone loss. The big one, the big specific test is a fever, like we've talked about in the past, right? So if my patient has an infection in facet joint, vertebral body, they have something like osteomyelitis, a fever is going to be the best bet. This is a big reason why, I'll be quite honest with you, when I was seeing a lot of post-surgical patients, I would take their temperature. I would take their vital signs, and I would take their temperature while I was taking blood pressure and whatever. And I used those tiny little strips that I could take their temperature. And I will tell you, we caught a lot of infection early just by taking temperature. So I would highly recommend taking temperature with your patients. What we're going to see as well is that MRI is going to be very sensitive and pretty specific to things like osteomyelitis. And in fact, what we'll see a lot of times is if my patient has a fever and they're having some low back pain, this is going to be one of the rare circumstances where we're going to take them straight to MRI and not necessarily put them in the X-ray machine first. As you can see from the bottom point here, plain radiographs are pretty sensitive. They have very good sensitivity. Specificity is not that great. 57% is okay, but it's not wonderfully fantastic. So typically these patients, when they have low back pain and they're running a fever, I want to at least screen them with an MRI. Now, obviously, as we know, we have a pandemic going on. So, and one of the main symptoms of COVID is a fever. But at the same time, I will say that that patient would have other signs and symptoms as well, but they don't necessarily belong in our clinic. So we do need to screen these folks. So if someone's having a fever, remember that's a big red flag. So we're on to slide 15. When it comes to spondyloarthropathies, the big one that we're going to see is going to be ankylosing spondylitis. You can see Reiter syndrome and psoriatic arthritis. It's not typically that common. Psoriatic arthritis can happen though. The big one we're going to watch out for, because it needs to be treated in a very specific way, is going to be ankylosing spondylitis. And specific to ankylosing spondylitis, there's something called the modified New York criteria. So modified New York criteria is going to be a really easy screening tool that you can use with your patients. So we're on to slide 16. Typically with ankylosing spondylitis, chronic low back pain patients, 95% of them do not have ankylosing spondylitis, but that means 5% do. Now, the scary thing is these are going to be those folks that come in and they've had a long history of low back pain, because it's typically about 7 years of low back pain, which is a long time, from onset of symptoms to a diagnosis. And that's because this is a very slow progressing disease. They will have several years of inflammation before you can actually see it on an X-ray. Typically, this will happen in folks under the age of 40. And typically, they'll have pain and symptoms for over 3 months, right? So if my patients come in, you ask them how long you've had low back pain, and they tell you, it's been about 3 or 4 years, and I finally just going in to get it. The antenna should go up a little bit, right? So you kind of start thinking, okay, what do I need to do here? So we're going to move on to slide 17. This is the modified New York criteria for inflammatory low back pain, and it's very, very good for ankylosing spondylitis. So I'm going to ask my patient, okay, they've had low back pain for 6-7 years. Tell me about it. How do you feel when you first wake up in the morning? Oh, I'm stiff as a board. How long does that last? Oh, it's a couple hours. Okay, so morning stiffness over 30 minutes long. That is a huge red flag. What makes it better? Oh, if I keep moving around and I keep exercising, I'm okay. But once I sit down, it is terrible. Improves with exercise, worsens with rest. That's another red flag. Okay, tell me more about your symptoms. Are you having any buttock pain? Yeah, it kind of goes from right to left and kind of alternates. Alternating buttock pain is a huge red flag for ankylosing spondylitis. And then, do you have any pain at night? Yeah, I do. Well, tell me about that. Is it the entire night? Is it first half of the night, second half of the night? Oh, it's typically that second half of the night. Like first couple hours I sleep fine, but then I just can't get comfortable again. Now, that's another big red flag for ankylosing spondylitis. Now, again, what we're going to see here is every one of those symptoms or complaints in isolation is not a big deal, right? Lots of things can cause morning stiffness over 60 minutes. Lots of things can cause pain to get better with exercise, worse with rest. It's when we start stacking those signs and symptoms together, right? So we start having those concordant signs, or a cluster, right, as the MSK term is used. So when my patient has 2 out of 4, they have a likelihood ratio of about 2.3. Okay, now I'm getting a little more specific. If they have 3 out of 4, that likelihood ratio jumps up to 12.4, right? So if my patient has morning stiffness longer than 30 minutes and alternating buttock pain, and it improves with exercise and it worsens with rest, that's a pretty good likelihood, right? We need to get that person in, and we need to get them at least screened for ankylosing spondylitis. So we're on to slide 18. Now, to confirm ankylosing spondylitis, what we're going to see is we're going to typically see radiographs, MRI, and a big blood test that specifically looks at the HLA-B27 white blood cell marker. So when that patient has, because ankylosing spondylitis is an inflammatory disease, right? So it's going to cause a white blood cell response. It's when that white blood cell is triggered, specifically the HLA-B27 white blood cell, it's going to be very sensitive to ankylosing spondylitis. MRI is typically going to be very sensitive as well. And typically what we're going to see is we're going to see what's called a sacralitis. So we're going to see inflammation of the sacrum, specifically the PSIS joints. And typically what we're going to see as well in more severe cases of ankylosing spondylitis is that we're going to see something called sacralization. And typically what sacralization is it kind of says what it is and is what it says. My L5 lumbar vertebrae starts fusing to my sacrum. And in fact, what we're going to see with ankylosing spondylitis is there's going to be a condition that's seen on radiograph that's called a bamboo spine. And the reason it's called a bamboo spine is because the spine typically looks like bamboo. You can see different rings and different parts of it, but it's all one big shaft of bamboo. All right, so we're going to move to slide 19. This is a big one as well. Differentiating peripheral vascular disease versus spinal stenosis is a huge thing. I would highly recommend when those folks come in with chronic low back pain or spinal stenosis, make sure that you know whether or not they have vascular claudication happening. So typically with vascular claudication, what we're going to see is a lot of the other stuff that we've seen already with vascular problems, right? So if we think about it, what's my vascular system do? It provides blood into my extremities and obviously my body. When I exercise, my muscles need more oxygen that's transported by red blood cells. We know that. If I can't get that blood to those muscles, what typically happens is typically those muscles are going to start aching, right? I'm going to actually cause an ischemic event to happen in the muscles. So a great way to determine whether or not someone has a vascular claudication is to place the muscles in that state where they actually need more oxygen and therefore more red blood cells, and see what happens, right? So if my patient has a compromised vascular system, typically they're going to have a ton of pain that happens when they have activity. So these are those folks you ask them, what makes your pain better and what makes your pain worse? Oh, I have this terrible low back pain and leg pain every time I walk. Well, what makes it better? Well, when I sit down, it gets better pretty quick. As soon as I sit down, it gets better, right? So that should kind of ping, kind of send up the antenna. Maybe this person has vascular claudication happening. Now with neurogenic claudication, this is typically what we're going to see with spinal stenosis and central canal So what's the difference between, that's a good question, PAD and PVD? Not a whole lot. Typically, those are synonymous terms. So typically with PAD, that's just peripheral artery disease. Peripheral vascular disease is going to be essentially the same thing. So that's a good question. So with folks with neurogenic claudication, more spinal stenosis, what we're going to see is central canal is going to be encroached upon. Typically, it's going to be aggravated by walking and relieved by sitting. Now, here's the problem. If you look up above, those are the same exact symptoms or the same exact ags and eases as PVD. So how do we differentiate? Is this person having a vascular claudication or are they having a neurogenic claudication? Typically what we're going to see is we're going to use something called the bicycle test. Okay, bicycle test, if you got a bike, you can do the bicycle test. Now what I will say is you can't use any bicycle. Okay, and the reason you can't use any bicycle is not going to work real well with a recumbent bike, and I'm going to show you why. So we'll move on to slide 20 here. Now, what my patient tells me in terms of quality of pain is going to tell me a lot. Also, a lot of their objective findings are going to tell me a lot. If this patient has low back pain that's vascular in nature, typically that patient is going to complain of throbbing pain. I might see a diminished or absent pulse, right? So don't forget about your pulses, right? Check out things like dorsalis pedis pulse. Check out things like, ankle brachial index, things like that, because that can give you a really good indication whether or not the vascular system is involved. If my patient, pulls up their pant leg and the leg is shiny, there's a lot of hair loss on the leg, it might be a little white, right? So there's some pallor or even blue or cyanotic. There's a good chance that person has some vascular stuff going on. If they're having pain in all positions, right? And that's going to be a really big one to understand here, because with our neurogenic spinal stenosis patients, typically what they're going to see is that they have relief in flexion. And typically with our neurogenic low back pain patients, it's something called a shopping cart sign. So a shopping cart sign, kind of says what it is and is what it says. If my patient says, oh, I get a ton of relief when I lean over on the shopping cart, that's a positive shopping cart sign. And typically what they're showing you and demonstrating is that prolonged flex positions or prolonged position of flexion provides them relief. And the reason it provides them relief is because, as you know, with flexion, it's going to increase the spinal canal, for lack of a better term, a little bit, and provides a little bit of relief off of the spinal cord, or a little bit of pressure decrease in the spinal cord. So what we're going to see is we're going to do this bicycle test with patients. We're on a slide 21 at this point. So this is the bicycle test. It's super duper easy. We need to have an upright bike to do this. Recumbent bike's not going to work. What we're going to do is we're going to say, okay, patient, I want you to get on the bike, and I want you to start pedaling. And patients go, okay. All right, and I want you to start pedaling until your pain starts increasing. So they go, 2-3 minutes, whatever it is. All right, ooh, yeah, my back's starting to hurt, my legs are hurting. Okay. Lean forward on the handlebars for me. Essentially, go get into that shopping cart sign position. All right, how's your back pain doing? How's your leg pain doing? Oh, it went right away. If it goes away, if it relieves with that forward bend, then they have the neurogenic spinal stenosis, right? They don't have peripheral artery disease or peripheral vascular disease. If it doesn't, right? So if they're pedaling and pedaling and pedaling and the pain's getting worse and they lean forward and it's still getting worse, they have peripheral artery disease or peripheral vascular disease. Okay, so that's really, really important to note. All right, so we're on to slide 22. So when it comes to GI dysfunction, this is we've gone over a lot of this so far in covering GI and viscera, both this semester and last semester. GI dysfunction in terms of low back pain are going to have associated signs and symptoms with the GI system, right? So if my patient's having pain, and what we're going to see this with a lot of folks, I need to take a little bit of history here, right? So here locally, 800 milligrams of ibuprofen is called Ranger candy. And there's a reason they do that, because they take it so much. So if they have chronic NSAID use, right? So if they're taking 800 plus milligrams of Advil or another anti-inflammatory, typically what can happen is they can have low back pain, but it's coming from something like a peptic ulcer. If they're on a lot of immunosuppressants, then we can typically see, or sometimes see, that because of those immunocompromised or immunosuppressants, and typically what you're going to see is folks that have had organ transplants are going to be on a pretty high dose of immunosuppressants. The reason is because if they're not, then the white blood cells will start attacking and rejecting that foreign organ. If my patient has history of something like Crohn's disease, which Crohn's disease goes by the name of ulcerative colitis, or if they have a history of cancer, sometimes they can have low back pain as well. But typically, what we're going to see is we're going to see those associated signs and symptoms that go with the GI system, right? So if my patient's having pain in their esophagus or pain with swallowing, well, it's probably not the L3 disc, right? If they're having kind of stomach pain and back pain, that doesn't go together, right? If they're having something like, I eat a bite or two and then I'm full, now that might be a sign of something like stomach cancer, not necessarily back pain. Or if they're having something like bloody diarrhea or incontinence, again, the L3 disc is not going to cause that. So just be very, very careful with associated signs and symptoms that we're screening for these, because my patient may have a lot of signs and symptoms that go with that. All right, so we're on to slide 23. So when it comes to specifically the liver and the biliary system, alcohol abuse or acetaminophen-based drugs are a huge red flag for this. Now, alcohol obviously is metabolized through the liver. Acetaminophen is metabolized through the liver. And I'm not sure if you guys covered this in the farm or not, but if you didn't, no big deal. Remember that your opioid-based medications, right, your Vicodins, Percocets, Oxycontins, when you look at the dosage of those, what you're going to see is you're going to see 5-325 or 10-325 or 375 or whatever the number is. The number behind the dash is the milligrams of acetaminophen in that medication. And the reason I bring this up is because a lot of folks, and just through lack of knowledge, lack of education, what they will do is they will take their pain medication after a total knee or after lumbar surgery or after something else. And then 2 hours later, they'll go ahead and take 2 or 3 Tylenol. And I really try to educate patients not to do that, because Tylenol toxicity is a real thing. And Tylenol overdoses is a real thing. And what I tell them is that you need to be really careful with that, because your pain medication already has a acetaminophen dose in it. And a lot of people don't realize that. A lot of people don't understand that that number, 325 or 375, is actually the milligrams of acetaminophen in that medication. So as we know, the liver can refer to pain to the right shoulder or mid-back, interscapular region. Typically, they're going to have pain after eating or consuming those medications or alcohol. And typically, they're also going to have something like ascites, right? Ascites is a really big sign and actually has a pretty positive likelihood ratio and good correlation with hepatic disease or cirrhosis of the liver. All right, so we're on slide 24. All right, so getting into some of the imaging here. what we're going to kind of cover today is the very basics of imaging with the lumbar spine. And what I will tell you is that lots of folks get x-rays and lots of folks get MRIs of the lumbar spine. It is, in fact, the single most over-requested diagnostic imaging procedure. And there have been some studies, and some studies have indicated up to 90% of diagnostic images that have been performed on patients were completely inappropriate. And we're going to kind of see why later on. And honestly, what it has done is caused a huge problem. There are folks out there who went and got, x-rays or MRIs done for low back, and it's led to inappropriate surgeries, or it's led to inappropriate injections or procedures that never really should have been done in the first place. And that's kind of the problem. What we're going to see with low back imaging is that with low back imaging, just because the image says something does not necessarily mean that's causing the problem. And that sometimes can happen is we start treating the image, we stop treating the patient. I'm going to ask you guys as clinicians, as future colleagues, please treat the patient, don't treat the picture. All right, so we're on to slide 25. So likely 1/3 to 2/3 of low back pain images are inappropriate. And here's why. Okay, and this is kind of the ugly side of medicine. I'm going to be quite honest with you. We get paid in medicine based on what we do. Unfortunately, we do not get paid in medicine to get people better. And that's the sad reality of it. And I hate to say that. So there are folks out there that take that to the nth degree, right? And they really do get incentivized by finances. So there are folks out there that, and I hate to say this, every patient that walks in gets images, and the reason they do is because they own the machine, right? So they're making money off those procedures. The other bigger reason, believe it or not, is actually patient demand. And this has been an issue probably since I've been practicing. Once we started offering procedures and advertising drugs on TV and radio and newspaper and things like that, patient demand has gone through the roof. The other big reason that a lot of providers will order images, it makes their job a little easier, right? So it's really nice and easy to say, okay, yeah, Mrs. Smith, this is why you're having low back pain. Look at this x-ray, right? There's a compelling nature of visual evidence here. Oh yeah, there's, look at that x-ray. I think that's what's going on. And it honestly validates the findings a lot of times. It does not necessarily increase the accuracy of the findings. That's the problem. And then honestly, the other big thing is fear of lawsuits, what's called defensive medicine. And this is kind of, the other ugly side of medicine as well. There's a big bias and big incentive out there to do extra procedures, to do extra things for patients, because you do not necessarily want to be negligent. And, it's gotten a lot better now. I can remember when I first got out of school, everybody got images. I mean, I kid you not, everyone got images that had low back pain. And the big reason was because a lot of providers did not necessarily have a financial incentive directly, right? They didn't own the machine, but their financial incentive was, I don't want to get sued, right? So yeah, I'll go ahead and subject that person to a little bit extra radiation because I just don't want to sit on a witness stand. So that's another big reason as well. So we're on to slide 26. So here's another sad stat for you. So between 1994 and 2006, when Medicare started covering MRIs for low back pain, there was a 307% increase in the use of MRI for low back pain. That's the sad reality of it. In fact, I think I told you guys this already, we have so many MRI machines in the US that if you turn them all on at the same time, we would shift the magnetic pole of the Earth 5 centimeters, I think it is. It's something sick like that. So there is some geographic difference, right? Depending on where you are in the nation, some regions are very heavy on spine MRIs. Some regions are very heavy on surgery. Some are not. And despite all the increases, despite all these folks getting extra surgery and extra MRIs and things, there's been no real change in the outcomes. So we're on to slide 27. This one's a huge one, okay? Star this one, hashtag this one, whatever you got to do. Know this slide. When does my patient need immediate imaging versus when can I do therapy first and then send them for imaging? Okay, this is a huge one because, and I will side note here, this one comes out straight out of Riemann's textbook, okay, as the next slide does as well. So when my patient has major risk factors for cancer, okay, new onset of low back pain with a history of cancer, right? Remember that history of cancer. Multiple risk factors or red flags for cancer, and a strong clinical suspicion, yes, please go send them in for radiography and erythrocyte sedimentation rate. If they have a risk factor for spinal infection, so remember, fever is very specific, right? So if my patient has fever, if they're using intravenous drugs, and that can be something that's prescribed, or that can be something that's not prescribed. And unfortunately, we do have some folks out there that are using recreational drugs intravenously. There's a good chance that they have a spinal infection as well. Or, as we can see from the other two bullet points, if my patient has Codd-Aquinas syndrome signs, they need to go in, right? Or if they have severe neurologic deficits, progressive motor weakness, progressive neurologic deficits, right? I'm getting weaker and weaker and weaker, right? I can barely walk at this point, and I could walk 2 months ago. Get them in for an MRI right away. Don't even do therapy on them. They need to go. Now, the other part of this chart, I'm going to do therapy first, right? So if I have a weak risk factor for cancer, if they're over 50 years old, maybe they have some signs for ankylosing spondylitis, maybe they have a vertebral compression fracture, but I'm not entirely sure, then let's do therapy first. If they don't get better, then yes, go send them for imaging. Even with our radiculopathy patients, right? If I'm seeing that radiculopathy patient and they're not getting better, then the first question you got to ask is, why am I continuing to see them? Or if I'm making them worse, why am I continuing to see them? And then they need to go in for an image as well. Obviously, if my patient is getting better, or if they're just not getting any worse, right? So they've had an image on the very last bullet point on that slide. They've already had an image, and there's no change in status. There's no reason to go get another image, if that makes sense. All right, so we're on to slide 28. This is another good slide to know. So take a look at sensitivity and specificity here. And this is kind of the sad reality, and this is why lumbar imaging is not necessarily the greatest thing to do in all periods of time. My gold standard for a lot of these is going to be some clinical findings, biopsy, surgery, right? And I'll just kind of break down that first point there. Lumbar disc herniation. We're going to see it a lot in the clinic. MRI and CT versus surgery is only about 75% to 77% sensitive. That means 1/4 are not showing up, right? And that's kind of an important point to remember, is that just because the MRI didn't show anything does not necessarily mean there's nothing going on, right? And I always tell patients, because I see this a lot, I actually see this a lot with my rotator cuff patients. Either the MRI will show them that the rotator cuff is just absolutely trashed and it's not that bad when they go in for surgery, or conversely, their MRI showed not really much of anything, and then the surgeon went in and holy cow, their rotator cuff was trashed. What I always tell folks is there's no substitute for the naked eye. right? There's really not. And you really kind of have to think about why we use images in the first place. We use images in the first place because I need to see inside somebody's body and I don't want to cut them open, right? I mean, that's kind of what we're doing. So just kind of take that information and kind of understand it, because realize that none of these tests that we do are going to be 100%. But it is a very good way in a lot of cases to screen for something without going through the time, cost, and healing process and lost work hours and everything else of having a surgery done. All right, so we're on to slide 29. So when looking and comparing MRI versus plain film radiograph, there's this group that did a study, and this study's getting a little old at this point. It's about 19 years old. And they randomized a group, and they said, okay, you people, you're going to get an MRI. You other people, you're going to get a radiograph. What they saw was that there's really no difference in outcomes after about a year. Treatment, anything like that, the groups were doing about the same. However, the group that got the MRI not only cost more because they actually had more procedures done, but the group that had an MRI actually ended up in surgery twice the time that the radiograph group did. Because MRIs are very, very specific and very, very sensitive, right? They pick up a lot of stuff. And what we're going to see is I'm not going to be able to see a disc herniation on an X-ray, but I sure can see it on an MRI. But just because I see it on an MRI does not mean it's necessarily the problem, right? And that's what we see a lot is these folks will go in these MRIs. I mean, heck, I just had one yesterday in the clinic, and MRI didn't look so hot. It does not necessarily mean that that is actually causing this patient's problems. So we're on to slide 30. So looking and comparing X-ray to no imaging whatsoever. Another study was done. Again, this one's getting a little old. They looked at 422 patients with low back pain, about 6 weeks to 6 months in duration. And half of them they didn't do imaging on, and half of them they did. What they saw is really no difference in outcomes. But the group that got radiographs were more satisfied with their care because they were doing something. And this is kind of the I won't say sad reality of it, but this is just kind of where we are in healthcare. 80% of the patients said if they were given the choice, they would pay extra for the benefit that they perceived by getting an X-ray, right? Just that knowledge of what's they think is going wrong in their body. And then a lot of times this is exactly what we're seeing is that patients are coming in and not necessarily asking our providers, hey, what do you think needs to happen? They're coming in saying, I need a radiograph. I need an MRI. So this is a big point to know. All right, so we're going to move on to slide 32 now. Okay, so we're going to skip over 31 because it's just a title slide, and then we're going to go into 32. So when I look at triaging my low back pain patients, when I'm kind of stratifying how severe these low back patients are, what we need to understand is non-specific low back pain doesn't necessarily mean much of anything, right? There's over 3,000 different causes of low back pain. Ankylosing spondylitis is one of them. So is my patient having non-specific low back pain? Are they having low back pain associated with a radiculopathy, stenosis, that sort of thing? Or are they having low back pain that's associated with another specific cause, right? Kind of that 2 to 3% we talked about at the very beginning of class. Are they having something like Cauda-Equina syndrome? Are they having a tumor? Are they having an infection? Right? Have they responded to specific treatments? Right? Things like ankylosing spondylitis, compression fractures, things like that. So what we need to understand is we need to understand that, like I said, only about 2 or 3% of our patients that come in are going to be non-mechanical low back pain. But we also need to understand that my low back pain patients can be something that they don't necessarily present as, right? So my disc herniation patient can turn into a cauda-equina patient, as we saw very earlier, pretty quickly, within 24 hours. But what we need to do is we need to kind of stratify and triage these folks into very specific categories. So we're going to move on to slide 33. So what we should do is when our low back patients come in, we don't necessarily just send them out to imaging right away, right? What we need to do is we need to do a focused history physical exam. I think your MSK curriculum does a really nice job in patient interviewing and getting to the root of the problem and being very thorough. What we should do is we should not routinely obtain imaging or other diagnostic tests for non-specific low back pain. So if a patient comes in and says, yeah, my back kind of hurts all over, and that's all they're having, they're not having radicular symptoms, they're not having claudication, they're not having urinary retention problems, don't send them out for an x-ray. Don't send them out for an MRI because there's no reason to. Imaging should only be performed for those with low back pain when they're having severe or progressive neurologic deficits or when something serious and underlying is suspected, right? So if my patient comes in, they're having low back pain and they had 30 pounds of weight loss, that's a big problem. Or they're having progressive weakness in their legs. That's a big problem. Yes, send those folks out for imaging. Clinicians should use MRI or CT for individuals with low back pain and signs and symptoms of radiculopathy or stenosis only if candidates for surgery or epidural steroid injection or have the above findings. So that's the other thing. Right? It's really the other thing you need to think about. Okay, so you go get that MRI. Sweet. Go get that CT scan. Fantastic. What are you going to do with the results? Right? If there's no plan for surgery or plan for epidural steroid injection, there's no point in getting the image, right? Because like we have learned already, a lot of times that picture won't show me exactly what is going on with that patient. All right, so we're on to slide 34. So sometimes early MRI can have what's called an iatrogenic effect. What iatrogenic means is that due to the activity of physician or therapy. So in other words, I didn't know I had the problem until I saw I had the problem, right? And this is kind of the issue with diagnostic imaging for lumbar spine. A lot of folks would go in and it's like, yeah, I kind of have this cramp in my low back, or I kind of have this, low back pain. Oh, well, your MRI showed that you have 5 levels of herniated discs. What? And so all of a sudden, oh my gosh, I have 5 levels of herniated discs. I'm going to lay on my back for the next 6 months, right? And that's kind of an exaggerated example, but it does happen. So Webster and his group in 2013 looked at about 1,000 workers for acute and disabling low back pain. What they found was there was a much lower rate. So what they did here was they actually looked at MRI specifically with this group. I should say that. So what they found was that the folks with MRIs versus the folks that did not get MRIs with low back pain actually went on disability a lot more frequently because, oh my gosh, I have this problem, I can never work again. And what they found was that the medical costs were through the roof, right? So about $13,000 per patient when that MRI happened early. So, if you look at it now, a lot of insurance companies will not allow an MRI to happen until somebody either has a finding that warrants an MRI or they've gone 4 to 6 weeks of conservative therapy first. So it actually is very common now. The insurance companies won't even pay for the MRIs anymore because of that. Not at the beginning, at least. So we're on to slide 35. So big thing to remember here is when our patients are going in and getting x-rays, remember that they are suspect and they're being subjected to radiation. And this is the big problem with the lumbar spine. Lumbar spine is in the back, which means you got to really crank up that x-ray machine in order to get a good picture. So the effective dose of an anterior posterior lumbar spine radiograph is equivalent to get 50 to 75 chest x-rays, depending on the person. That's a lot. And what we see is that the AP view is a considerable amount greater in terms of radiation dosage versus lateral view. All right, so slide 36. This is the really scary part. So CT, as we know, is a whole bunch of x-rays. So if my patient has a lumbar CT scan, they have just received 500 chest x-rays. That is a ton. So this is kind of the sad part of it, is one lumbar CT scan exposes my patient to more population than the folks that went through Chernobyl in rural Ukraine. That's the sad part of it. So I really need to be careful. I really need to be selective with who's getting radiographs and who's getting CT scans. And this is the other big reason why MRIs typically are not necessarily the default, but they are very well, let's say, preferred. Because remember, with MRI, my patient doesn't get any radiation. But as we've seen, getting an MRI can lead to a lot of other problems. So this becomes, unfortunately, a little bit of a medical ethics class in addition to imaging and medical screening. All right, so we're on to slide 37. So big thing when you're thinking about getting your patient an image for their low back, consider the diagnostic yield, right? What's my bang for my buck, right? What's my cost benefit ratio here? Please use shielding, obviously, and go for the lowest dose view. So don't go for the oblique view right away. As we're going to see, the oblique view is going to expose my patient to the most radiation. And in fact, what's going to be actually a better idea is don't use the AP view, especially for something like scoliosis. Use a PA view, right? Because then if I place my patient prone and shoot the radiation from posterior to anterior, it's going to hit the low back first versus all the organs and other stuff it has to go through. And in fact, especially with scoliosis, because they're going to go through so many x-rays, right? They're going to go through a ton of x-rays because we will obviously want to see the change in the scoliosis as they age. If I use that PA view versus AP, then I'm going to have a 3 to 7 time reduction in radiation. That's huge, right? So really simple difference, really simple change can have a pretty wide impact on these folks. All right, so we're on slide 38. So basic terminology, I'm not going to spend a ton of time on this. This basically, we went over this the very, very first class. So just understand what all these terms mean. Something's radio-opaque, something's radiolucent, right? Things like that. All right, on to slide 39. We're almost done, guys, I promise. So the big views that we're going to see here for the lumbar spine, we're going to see an anterior posterior view. That's going to be the big one. We're going to see a lateral view. Those are done pretty routine. There's something called a coned view, and basically all a coned view is, it gives you a little different look at the L5S1. And basically what you do is you just kind of adjust how the radiation is coming out of the beam. So it doesn't come down in a big cylinder. It actually gets scattered a little bit into a cone. It just gives you a little different view of L5 and S1. And that's simply used because the L5-S1 interface is just a little differently shaped than the other lumbar interspaces. There's also that oblique view. Remember that an oblique view is going to expose my patient to the most radiation out of all of these. And then we can do those flexion and extension stress views, just like we saw with the cervical spine as well. This is typically what I'm going to see for the AP view of the low back. So I can see a lot of stuff here. I can see the alet of the sacrum. I can see the sacrum itself. Take a look at how those lumbar vertebrae look, right? So we already kind of talked about in the thoracic spine, that owl sign or winking owl sign. I can still kind of see that owl happening here. So just, like I said, good slide to know for labeling and testing purposes. So if I throw up a lumbar spine label and point to it, please know what everything kind of looks like in an AP view. All right, on to slide 41. Same thing goes for the lateral view. Now, with the lateral view, obviously we get a little different look here of the facet joint. We can kind of see it superimposed. We get a much different look of the spinous processes. And we get a much different look at intervertebral spaces here as well. Now remember that the lateral view is going to expose my patient to the least amount of radiation. But I'm going to see those same lines, if you guys remember from last semester, for the cervical spine, right? So I kind of have that anterior line, that midline, the posterior line. Understand as well, when we're looking at something like spondylolisthesis, that those lines are going to become very important, right? So if I have a slippage of the L3, for example, I will see that those vertebral bodies are not necessarily in that nice arced line. So on to slide 42. This is the coned view of L5S1. Like I said, it just gives you a little different view of L5 and S1. It's a nice way to look at the lumbosacral junction at that interface. But with the coned view, because you have to adjust the machine so much and you have to kind of point the beam specifically at L5 and S1, you're not going to get to see the entire lumbar spine. You're basically going to see a lot of the sacrum and L4 and L5. That's basically all you're going to see. And a lot of times it's just L5. And on to slide 43. We'll pick up with this next week because we're going to kind of talk about what the oblique projection is. With the oblique projection, remember, huge increase in radiation, a 75% increase, in fact, in radiation when I use the oblique view. Typically, we're going to use the oblique view when I suspect my patient has a spondylolysis, right? So they have a broken pars denticularis. And what we're going to see is that there's going to be something called the Scotty dog, and we'll get into this a little bit next week. And when my Scotty dog has a little broken neck, that is indicative of a spondylolysis or a fractured pars denticularis. All right, guys, we made it through it. Okay. Any questions for me? If you don't, that's perfectly fine. If you do, that's perfectly fine too. All right, what I'll do is Microsoft Teams will process the audio of this. I'll put the audio on, and you guys can just kind of follow along in the slides if you want as a recorded version. Other than that, I hope everyone has a really good weekend. Watch out for Snowmageddon 2 here this afternoon.